around 12 minutes past 11 before I finally contacted Jonathan and told him that we are going to have to postpone the class. Yes, because I have no intention of giving the lecture using my um, hotlink data because I'm only using hotlink, and also because of uh, there'll be no apa namanya fan or aircon in my house without electricity, so I will not be able to lecture lah. Okay, but surely enough, yesterday after I told Jonathan, so only about 10 minutes after that, then the electricity was restored. But since at that moment, Jonathan had already scheduled the replacement today, so here we are today lah. Okay, the session today will probably be uh, a bit shorter than yesterday, primarily because this is pretty much only a revision session. Okay, all the drugs that I am going to mention today, you have already learned during the general pharmacology block. Okay, if somehow you feel that the drug is rather unfamiliar, actually you are familiar with the drug. It's just the same drug in the same class, but probably with a slightly different name, signifying the difference in generation. Okay, uh, for example, probably you have been learning about cephalosporins, first generation, second generation. Now we have even fourth generation cephalosporins. So before you panic looking at the many names of drugs, okay, please realize that you have actually learned about all these drugs before. And today is just pretty much like a revision session, and I'm just going to highlight a few things and give you a few tips on what to remember, what you really need to understand in terms of the pharmacological treatment of respiratory infections. Okay. Obviously, today we are going to focus the discussion on antibiotics, okay, on antibacterial and antiviral drugs, okay. But nevertheless, these are not the only drugs that are given in disease setting, in, for example, the respiratory infection. Okay, so for example, some of you may be aware, for example, in the treatment of the coronavirus that we are facing right now, it's not just about treating the patient with an antiviral drug, okay, but there are also adjunct treatments that is useful in the situation. For example, giving steroids, which has been shown to really improve the prognosis of a patient. But I'm not going to really discuss about all that today lah. But just so that you keep that in the back of your mind. It's not just about the antimicrobial treatment. It's also the adjunct treatments that actually help the patient to recover. Okay. So before I proceed for today, just a couple of questions that I got from yesterday. Okay. Number one is on histone acetylation and theophylline. Okay. So I think I told you already yesterday, two main mechanisms for the mechanism of action of theophylline. Okay, one involves phosphodiesterase, the other involves adenosine. Okay, and the third mechanism, if you refer to catzone, there is also a third mechanism that involves the acetylation of histone, or the enzyme HDAC. Okay, so in order to apa namanya, in order for theophylline to work, okay, it has to ultimately it will want to reduce inflammation. Okay, and one of the mechanisms by which theophylline is postulated to reduce inflammation is by the uh, inhibition of the HDAC. Okay, that is also the same mechanism that is postulated to be used by steroids. Okay, so it is not just apa namanya, theophylline that makes use of this histone deacetylase. Okay, but it is also steroids. Steroids are also thought to reduce inflammation using the same mechanism. Hence, why it has been shown in clinical studies that if theophylline is given together with steroids, you get a synergistic or additive effect to the treatment. So that was the question yesterday, and so yes, you will definitely get a better effect when you give theophylline and corticosteroids together. Okay, and part of the reason is because they act on the same mechanism involving histone deacetylase. Okay, you can refer to catzone. Catzone, when describing the mechanism of action of theophylline, in the very last paragraph, at least catzone 13th edition, at least in catzone 13 edition, in the very last paragraph describing the mechanism of action of theophylline, it mentions the role of histone deacetylase, the enzyme. The other question from yesterday is whether whether you need to remember all the mechanisms underlying corticosteroidal adverse effects. We're talking about the Cushing effect, okay, due to steroids, and whether you need to know the mechanisms underlying those adverse effects. First of all, you should not treat them as adverse effects. It is effects of steroids. So steroids, glucocorticoids, mineralocorticoids, they are an essential part of your core knowledge. So you do need to know how the steroids actually cause all these kinds of problems. So for example, in the picture that I gave you here, yes, you do need to know why osteoporosis with steroids. Is it because of an increase in catabolic, or rather in anti-anabolic effect in the bones, for example? Okay, so similarly in the skins, okay, you get thin skin, you get thin skins and also thin extremities. Is it because of an anti-anabolic or catabolic effect there? So it's the same, it's pretty much the same mechanism, and you do need to be able to explain that. Okay, some other things are probably a little bit more long-winded, the explanation. For example, fat deposition giving you the moon face appearance or your buffalo hump appearance with steroids. So yeah, but yes, you do need to know a little bit about the pathophysiology behind that. Okay, and there are also uh, some effects that are a little bit more important in terms of understanding the mechanism. For example, hyperglycemia. You definitely need to know how steroids cause hyperglycemia, or how steroids cause sodium and fluid retention eh, through its mineralocorticoidal effects. So you do need to be able to explain that, not just as an adverse effect of steroids, but as a physiological effect of steroids, of glucocorticoids as a whole. Okay, so you do need to be able to explain some of that. Okay, so please be wary of the requirements. Okay, so those are what we have learned yesterday. Okay, so today we are going to move on with the pharmacological management of certain respiratory infections. So obviously I will not be able to go through everything, okay, but this session is pretty much more or less a review, as I said, a review of the drugs that you have already learned in year one. Okay, TLOs for this session, okay, again is MOA, pharmacokinetics, adverse effects, interactions, clinical indications, and also, okay, forgot to write that down here. It should be also the mechanism of resistance. Okay, so the mechanism of resistance, okay, is something that you have learned before. Okay, you will know that certain drugs, the resistance develops because the drug is being pushed out from the bacterial cell. This is the role of efflux pumps. You know that certain drugs, okay, certain bacteria, they are resistant to drugs by denying the uptake of the drug into the bacterial cell. You know of some bacteria that actually inactivate the drugs using certain enzymes. You know that there are certain bacteria that would bypass the effects of the drug. The drug is supposed to inhibit here. The drug is supposed to inhibit whatever process in the bacterial cell, but the bacteria develops an alternative pathway leading to resistance. And there are also instances of the development of resistance where there are target alterations in the mRNA or in the process of protein synthesis. Okay, so those are the things that can occur. Those are the things that can occur in the development of resistance. And these are the sort of the summary of the mechanisms of resistance in bacteria and also in viruses. Having said that, there are a few mechanisms, okay, or there are some mechanisms of resistance which are, number one, more well understood, and number two, not just theoretical in nature. If you read up a bit the journals and all the recent articles, when we talk about the development of resistance in terms of efflux pumps, for example, where is my mouse? In terms of efflux pumps or in terms of decreased intake, these things are not exactly, well, not established, bukan tak established lah, but it's a theoretical discussion. The theoretical discussion is still going on. So usually if you want to ask in detail about these mechanisms of resistance, we reserve that to discussion with the postgraduates. On the other hand, you have a few mechanisms. For example, the inactivating enzymes, for which the mechanisms are much more established. We understand quite a bit more in terms of the science behind it. And there are a few drugs, there are a few bacteria that already exhibit these mechanisms of resistance quite clearly in terms of the science. So these kind of questions in terms of the inactivity enzymes is more commonly asked at undergraduate level. So that's one tip for today. Okay, if you have to worry about the mechanisms of resistance, okay, so you still need to know everything in terms of the mechanisms of resistance. What are the mechanisms? But the one that you really do need to understand and to remember in detail is your inactivating enzymes, which we are going to discuss a little bit more in a short while. Okay. So when we talk about respiratory tract infection, okay, today we are going to talk about bacterial and viral and also mycobacterial. Okay, you've gone through your first PBL on tuberculosis, so I'm not actually going to apa namanya, go into the anti-tuberculosis drugs so much today, because you've already learned that during the PBL and you've already presented. So again, it's just a review of whatever you have learned. Okay, and when we talk about respiratory tract infections, there is also some books who like to further subclassify it into upper and lower respiratory tract infections. So I'm going to show you that as well, which one is upper, which one is lower. Okay, but ultimately the drugs that are listed in these lecture notes, they are all examples of the empirical therapy that we give to patients, okay, which is based on the norms, based on the clinical practice, the usual practice in Malaysia. Okay, but at the end of the day, as you have learned in general pharmacology, when you treat a patient with an antibacterial drug or antiviral drug, yes, you start off with empirical therapy, but once you have identified the organism, okay, once you have identified the organism and once you have determined the sensitivity of that particular organism to a particular drug, then you will change your therapy from empirical to definitive therapy. Okay, that is the rule. Okay, but the ones that we are going to go through today is mainly the empirical treatment. But the rule is you always do for bacteria, you always do culture and sensitivity. For viruses, you identify the organism via reverse transcriptase, PCR or whatever. Okay, so it's this is how you do things, empirical and then definitive. Okay, so let's take a few examples on the drugs that are used for the treatment of URTIs, okay, upper respiratory tract infections. Okay, for example, something that maybe some of you would be suffering from time to time. Those of you who have recurrent episodes of tonsillitis, you may want to consider having your tonsils removed. I also from time to time suffer from tonsillitis, but I haven't had my tonsils removed because I'm afraid to go under the knife. Okay. Anyhow, okay, for tonsillitis, the main suspected organism is usually group A strep. Okay, very simple. Group A strep, and the treatment is also very simple. If it's group A strep, if you suspect group A strep, the patient is usually treated with penicillin V or penicillin G, okay, together with amoxicillin. Okay. If the patient is allergic to penicillin, then consider erythromycin, which is a protein synthesis inhibitor. So remember again the main classes of antibiotics. Main classes of antibiotics, you have your cell wall inhibitors, protein synthesis inhibitors, okay, and your DNA synthesis inhibitors. All those different drug classes will be mentioned today. Okay, so tonsillitis by itself, okay, is usually not a problem. Okay, but if tonsillitis is complicated with a peritonsillar abscess, okay, a peritonsillar abscess, then you have to consider other organisms as well. So it's not just group A strep, it may be Staph aureus, which can still be treated with and then you have to consider Haemophilus influenza, okay, and Fusobacterium necrophorum. Okay, and for those organisms, you consider the use of ampicillin and sulbactam. The slash there is actually means that you give it together. Ampicillin should be given together with sulbactam. Amoxicillin should be given together, must be given together with clavulanate. Okay. The last option is benzyl penicillin and metronidazole. Okay. What is the purpose of giving metronidazole? Based on the 4 organisms that is shown there, why do you give metronidazole? For which mechanism? Anyone? For which mechanism? For which organism?
Fungi.
Fungi, because there's an azole at the end.
Candida.
Say again?
You give it for candidiasis, is it?
Candidiasis. Well, okay. If it's fungi, yes, you treat them with azoles, but metronidazole is a bit different. Anybody know what metronidazole is for?
Is it helminthic?
Antihelminthic, okay, but I don't see any helminths there.
Isn't it anti-emetic?
Anti what?
Emetic.
Anti-emetic. Emetic apa?
The one that to recover from nausea and
yeah. Nope. No. Not really. So what are we using metronidazole for in this case? Okay, online classes very easy. You can just Google the answer. What is it? Metronidazole for?
Is it for nucleic acid synthesis inhibitor?
Yes, that's the mechanism. Okay. The mechanism of action of metronidazole involves breaking DNA strands. Okay, so yeah, that's correct. But why do we give it in this case? Because in peritonsillar abscess, there is a high index of suspicion for anaerobic bacteria. So, in fact, anywhere in your body, when you start to deal with an abscess, okay, when you find an abscess anywhere, you always consider the possibility of the abscess being caused ataupun having the presence of anaerobic bacteria. So Fusobacterium necrophorum is an example of anaerobic bacteria. Okay, so that is the reason why you give metronidazole to cover for your anaerobic bacteria. And that reason when you go for your housemanships in like 3 years time, okay, when you get posted into the surgical wards, you always see metronidazole being prescribed. So number one, they get a lot of abscesses over there. In surgery, you deal with a lot of abscess. Okay. Number two, you also deal with a lot of anaerobes. When you do general surgery involving the abdomen, there's always the possibility of anaerobic infection. So usually the surgeon will always cover with metronidazole. Okay. If there is an abscess, what do we do to the abscess itself? What about the abscess? What do we do to it?
Drain it.
You drain it.
Drain it. Most basic concept. If there's an abscess, drain the abscess. If you cannot just rely on giving, well, you can try lah. You can try giving antibiotics first. But drainage is always an important step to attempt as well. Okay, so remember metronidazole. Remember anaerobes. So this metronidazole is not an antifungal, although the name is azole at the end. So try not to confuse yourselves. Satu je, metronidazole. Okay, and so you can see there how it works. It works by breaking the DNA helix, and its ability to act in, where is my mouse? Its ability to act in in anaerobic bacteria is dependent on this process here, which is mediated by I don't remember the name of the enzyme. I think it's ferredoxin oxidoreductase. I think you can Google that up. And this is the reason why it is able to act in anaerobic bacteria. Don't worry too much about this lah. This one is nice to know, not need to know. Okay, the need to know thing is the mechanism of action, which is DNA fragmentation. Okay, so that's metronidazole. Okay, but the other antibiotics is perhaps a little bit more familiar. Okay, so your penicillin, okay, acts as cell wall synthesis inhibitors, and that is achieved by prevention of cross-linking of peptides from binding to the tetrapeptide side chains. So this one you know already. Okay, it's just a matter of revision. Okay, let's do questions 1 and 2. Shall we do it like yesterday? I need to open a random number generator. Oh, it's already there. Okay, number 14. Number 14 is Lim Chun Yu. Lim. Where is Lim? Please answer question number 1.
Hello, doctor. Can you hear me?
Yeah, yes, I can hear you.
So question number 1 is the difference between, right?
Yeah.
The difference between penicillin G and penicillin V. Penicillin G is administered intravenously or intramuscularly, while penicillin V is usually in an oral form of penicillin and is more acid stable. And then
Is that all?
there's one more. The penicillin G is effective against a wider spectrum of bacteria compared with penicillin V.
Okay.
Yeah, that's all.
Okay, good. Okay, that's exactly the answer that I'm looking for. So this is just a warm-up question, easy question there. Okay, just the difference between penicillin G and penicillin V, and the difference is mainly in the route of administration. Okay, question number 2. Next. Next. Okay, will be number 52. 52 is Lubana. Lubana ada ke? Is Lubana still with us? People from M12, is Lubana still with us? I'm kind of confused now.
Yeah, she is doctor. It's just she's not in Malaysia currently.
Okay.
Yeah,
Is
she's
she in
overseas.
this? Is she in the session? Calling once. Calling twice. Okay, Lubana tak ada. We have to try someone else. Number 80, 80. 80 is Faida. Faida, are you there? Faida, are you there? Calling once, calling twice. Okay, that's a little bit disappointing. 2 misses already. Next try. 74. Have you had 74 yesterday? No. 74 is Nurul Ashikin. Okay, Nurul Ashikin, please entertain us with your answer.
Yes, doctor. Wait a minute.
Yeah, okay.
For question 2. A combination of amoxicillin broad-spectrum penicillin and clavulanic acid will result in potentiation to increase effect of amoxicillin. It is a good infection. Organisms such as Staphylococcus aureus produce beta-lactamase enzyme, which can break beta-lactam ring in amoxicillin, which will terminate antibiotic activity. Thus no effect of amoxicillin. Beta-lactamase enzyme will produce a resistance to antibiotics, and clavulanic acid is a drug that will inhibit beta-lactamase enzyme to prevent breakdown of beta-lactam ring in amoxicillin. This will effect of amoxicillin. That's all.
Okay, very good. Okay, that's exactly the answer that I'm looking for. Okay, and as I mentioned earlier, this is the most common question on bacterial resistance that you are ever going to have. If there is something that you really need to describe in detail, in terms of mechanism of bacterial resistance is always has got something to do with the beta-lactamase. So you have to describe your beta-lactam drugs, your beta-lactam antimicrobials. They have a beta-lactam ring. Okay, the B here, they have a beta-lactam ring, which is susceptible to cleavage by beta-lactamase produced by resistant bacteria. So penicillin, cephalosporins, their beta-lactam ring is very susceptible to beta-lactamase produced by resistant bacteria. Okay, so how do we solve that problem? How do we solve that problem? We give, for example, amoxicillin. The most common example is amoxicillin is given together with clavulanic acid or clavulanate, which actually will inhibit the beta-lactamase. So that is the basic mechanism of bacterial resistance in beta-lactams and how we deal with that problem by giving clavulanic acid. Okay. There are slightly more recent cell wall synthesis inhibitors which also have a beta-lactam ring, but their beta-lactam ring is more resistant to beta-lactamase. So meaning these drugs do not need to be given together with clavulanic acid. Their beta-lactam rings are good. They don't have to be, they are not easily destroyed by the bacterial beta-lactamase. Okay. So the problem with beta-lactamase, especially with penicillin and especially with the older generation cephalosporins. Okay, so let's have a look at another example of a URTI. In this case, it's diphtheria. Should have been eradicated already, but mutations and also problems with people who are anti-vaccine. We are seeing a rise in diphtheria cases. We used to have 0. Last year we have a few. I think it's less than 10, I think. Okay, but it's rising lah. It's rising. Okay, and we have to think about how we are going to treat this bacteria. Fortunately, it is still susceptible to penicillin, so that's good. Okay, and you can also choose to treat diphtheria using erythromycin, which is a protein synthesis inhibitor. Okay. Don't forget, if you want to treat diphtheria, the patient needs to be treated with a diphtheria antitoxin too. Okay. So this is just showing you one of the more not common, but something that we would be wary of. It's not a common adverse effect, but it is an adverse effect to watch out for in patients who are receiving erythromycin. Okay, what is the problem? The problem of QT prolongation. So in patients receiving erythromycin, you may see in the ECG when the patient is being followed up, you may have instances of QT prolongation. Okay. Extrapolating from that, okay, if it's any worse than QT prolongation, you may have, anybody can tell me what that is? The ECG reading from the bottom there?
Procès d'avoir.
Okay, very good. So that's your tosa de pois. I'm not going to pretend I know how to pronounce it lah. Anybody learn French in school? I didn't learn French in school. So I'm not going to pretend that I know how to pronounce it. But as far as when I Google the pronunciation, the S is supposed to be silent apparently. So it's tosa de pois, something like that lah. Okay, so I'm sure you've learned about tosa de pois with Prof Latif. Did Prof Latif have the opportunity to meet you or not during CVS? Did he actually teach you or was it someone else?
That lecture he wasn't available, so Dr. Muhammad taught.
So who taught you arrhythmias?
For-
Dr. Muhammad?
Yeah, he said it's ventricular fibrillation.
Okay. Okay lah. Usually Prof
The
Latif
English term is easier.
usually Prof Latif would be very passionate teaching about the arrhythmias, but don't worry lah. Later on when you go on to the clinicals, you will meet him again. Okay, so more severe but rare adverse effect of erythromycin is tosa de pois. Okay, so something for you to think about. Okay, so don't forget that. Okay, so that is diphtheria. Here's another example of a URTI. Okay, and in this case is acute epiglottitis. Okay, and this is usually caused by Haemophilus influenza type B or strep pneumonia. Okay, and how do we treat it? We treat it usually with ceftriaxone or ampicillin sulbactam. Okay, and the patient is discharged usually with co-amoxiclav. Co-amoxiclav is amoxicillin plus clavulanic acid. Okay. If the patient is allergic to penicillin, okay, remember, if a patient is allergic to penicillin, there is a high probability that the patient will be allergic to other drugs of the same class. Okay, so what do I mean by class? If a patient is allergic to penicillin, there is a high probability that he will also be allergic to other cell wall inhibitors or other beta-lactams. So you have to think about that. So if a patient is penicillin allergic, you try to give something else. In this case, if there is suspicion of allergy or if there is confirmed penicillin allergy, you consider clindamycin plus ciprofloxacin. Okay. And lastly, if acute epiglottitis, if it occurs in the hospital setting, okay, if acute epiglottitis occurs in the hospital setting, you have to consider, or if it's severe, if it happens in the hospital setting or if the presentation is very severe, you have to consider MRSA. What does MRSA stand for?
Methicillin resistant Staphylococcus
Methicillin
aureus.
resistant Staph aureus. Okay, so if it's MRSA, the treatment of choice is vancomycin. If it's MRSA, the treatment of choice is vancomycin. Okay, so that is what we hope will work against MRSA. Although nowadays, well, it's been going on for a few years When MRSA first came about, we were quite worried and that this is going to be the end of days in terms of and there will be no antibiotics left that will be able to treat MRSA. And then we found out that vancomycin is able to treat it. It is susceptible. Okay, so we were happy about that. But now, the last few years, not even the last few years, last 10, 11 years, we are now worried about VRSA instead. Okay, right? So instead of MRSA, methicillin resistant Staph aureus, okay, you now have some books will call it VRSA, some books will call it VISA, vancomycin intermediate, okay, resistance. So this is a problem with vancomycin. Okay, so even vancomycin that is supposed to be able to treat a lot of organisms is now having problems of resistance of its own. So you can see there at the bottom there, vancomycin resistant staphylococci. Okay, we talked about co-amoxiclav. We talked about amoxicillin plus clavulanic acid. Okay, there's also another one, ampicillin plus sulbactam. Okay, which is the same. It's the same approach. So if you give amoxicillin plus clavulanic acid acts to deactivate the beta-lactamase produced by the bacteria. In the case of ampicillin plus sulbactam, it is also the same. So you can see the chemical structure is also similar. Okay, so sulbactam acts the same way as clavulanic acid by deactivation of beta-lactamase. So clavulanic acid, ampicillin and sulbactam is one of the choices for you to treat acute epiglottitis. Okay, what was the other choice just now? Okay, if the patient is allergic to penicillin, allergic to cell wall inhibitors, you may want to consider giving protein synthesis inhibitors instead. So in the case of epiglottitis, acute epiglottitis, you probably want to try clindamycin. Clindamycin acts by acting on the 50S subunit. Okay, it acts on the 50S subunit. So when you are answering questions related to antimicrobial mechanism of action, you need to go in a little bit more detail in terms of its mechanism. So if you just answer chloramphenicol, the mechanism is protein synthesis inhibitor, you are not going to get full marks. If you answer tetracycline, the answer is protein synthesis inhibitor, you are not going to get full marks. You need to go a little bit more. You definitely have to mention to which ribosomal subunit does the drug bind to. Is it 50S? Is it 30S subunit? And what actually happens from there? Is it prevention of peptide chain elongation? Is it prevention of formation of peptide bond? Okay, is it interference? Is it codon misreading? So you need to describe in a little bit more detail. Most SAQ questions at the end of this block, if there are any, or in your first professional exams for the mechanism of action of drugs, usually the marks allocated will be 2 marks. Usually the marks allocated will be 2 marks. 2 marks means that you need to give away 4 points, 4 main points. So if you just mention protein synthesis inhibitor, you are not going to get full marks. You need to be able to elaborate a little bit. And that goes for all kinds of antibacterial drugs.
Doctor, I have a question. In the case of erythromycin, because it's a macrolide, when we did the introductory pharmacology, we mentioned that the table you put for us in the slides mentioned that it inhibits translocation during protein synthesis. And in this slide, it talks about acts on the 50S ribosomes and prevents peptide chain elongation. Is it the same?
Yeah.
Does it mean the same thing?
It's not exactly the same thing, okay? And if you read other textbooks as well, you are going to get slightly different answers. Okay, you are going to get slightly different answers. Okay, but don't worry about that. Okay, the main thing is as long as whatever you've answered in an SAQ setting, in an SAQ setting, but as long as whatever you've answered is something that is well established, and then you will get the mark lah. Okay, so there will be slight allowances to have differences in the mechanisms of action. So you don't have to follow just one book. We will consider all that. But in terms of your own studying, I suggest that you pick one mechanism and you stick to it lah, and don't have to consider all the other mechanisms or the theoretical mechanisms especially. So you don't have to worry about it. So for macrolides, you can mention binds to 50S subunit, prevents peptide chain elongation, or the mechanism that you mentioned just now, it still be okay in terms of answering an SAQ. If this kind of question comes up in an SBAQ, it will not be as complicated as that, because we know that if we put those two answers together in your ABCD options, you are going to argue lah, this one is correct or the other one is correct. So we always prevent that from happening. So we're not going to give two answers that are too close or two answers that are both correct. It's going to be one single best answer. Does that answer your question?
Yes, doctor. Thank you.
Okay. All right. And if you see the previous slide, the option for clindamycin, if the patient is resistant to penicillin, to cell wall inhibitors, is you give clindamycin together with, what is it? Ciprofloxacin, kan? Is it ciprofloxacin or levofloxacin? Ciprofloxacin. So ciprofloxacin, let's just watch a video. I think I have a video for this one. Let's have a look at the mechanism of action of ciprofloxacin, your quinolone.
In this animation, we demonstrate the biology of DNA replication, leading to bacterial cell division in a gram-positive bacterium, such as S. pneumoniae. The DNA is shown as a circular double strand within the bacterial cell. Like the DNA of all living organisms, it contains the unique genetic code for all of the proteins required for bacterial survival. Bacteria replicate by a process known as binary fission, whereby one bacterium separates into two new daughter cells. However, before this can occur, the bacterium must make an identical copy of its complete circular DNA. DNA replication requires that the two strands of DNA separate so that the genetic code of the bacterium can be read and a new complementary strand can be created for each of the original strands. To accomplish this, various enzymes, known as helicases, break the hydrogen bonds between the bases in the two DNA strands, unwind the strands from each other, and stabilize the exposed single strands, preventing them from joining back together. The points at which the two strands of DNA separate to allow replication of DNA are known as replication forks. The enzyme's DNA polymerase then moves along each strand of DNA behind each replication fork, synthesizing new DNA strands, in red, complementary to the original ones. As the replication forks move forward, positive superhelical twists in the DNA begin to accumulate ahead of them. In order for DNA replication to continue, these superhelical twists must be removed. The bacterial enzyme DNA gyrase, which is also known as topoisomerase II, is responsible for removing the positive superhelical twists so that DNA replications can proceed. DNA gyrase is an essential bacterial enzyme composed of 2A and 2B subunits, which are products of the GYRA and GYRB genes. This enzyme has other important functions which affect the initiation of DNA replication and transcription of many genes. With the combined involvement of these enzymes, an entire duplicate copy of the bacterial genome is produced as the two replication forks move in opposite directions around the circular DNA genome. Eventually, as the two replication forks meet, two new complete chromosomes have been made, each consisting of one old and one new strand of DNA. This is referred to as semi-conservative replication. In order to allow the two new interlinked chromosomes to come apart, another bacterial enzyme is needed, which is known as topoisomerase IV. This enzyme is structurally related to DNA gyrase and is coded for by the PARC and PARE genes. Topoisomerase IV allows for the two new interlinked chromosomes to separate, so that they can be segregated into two new daughter bacterial cells. This animation will demonstrate two mechanisms of fluoroquinolone action. Fluoroquinolone antibiotics, shown here, are synthetic molecules that are bactericidal. The potency of these drugs is greatly improved by the addition of a fluorine molecule at position 6, and thus the term fluoroquinolones. Fluoroquinolones rapidly inhibit bacterial DNA synthesis, resulting in bacterial cell death. Although much is known about the molecular events that underlie the action of quinolone antibiotics, much remains to be clarified. Fluoroquinolones act by inhibiting the activity of both the DNA gyrase and the topoisomerase IV enzymes. For most gram-negative bacteria, DNA gyrase is the primary fluoroquinolone target. Fluoroquinolones have been shown to bind specifically to the complex of DNA gyrase and DNA rather than the DNA gyrase alone. As a result of this binding, quinolones appear to stabilize the enzyme DNA complexes, which in turn results in breaks in the DNA that are fatal to the bacterium. A second mechanism of fluoroquinolone action is shown here. With some exceptions, topoisomerase IV is the primary target of fluoroquinolone action in most gram-positive bacteria, such as Staphylococci and Streptococci, with DNA gyrase being a secondary target. The separation of two new interlinked daughter strands of circular DNA is disrupted. The final result on the bacteria, however, is the same. Bacterial replication is disrupted and the bacterium breaks apart. The relative potency of different fluoroquinolone antibiotics, and thus their spectrum of activity, is dependent in part on their affinity for either DNA gyrase or topoisomerase IV, or both. One of the most common mechanisms.
Okay. Did I show you the same video in first year? I did, right?
No, I don't think so.
I don't remember. Supposedly I should have shown you that in first year as well. Well, anyway, so that's your quinolones. Just a quick review of the mechanism of action. So remember, you have to mention two enzymes, DNA gyrase and DNA topoisomerase IV. Okay, so now let's have a quick look at the lower respiratory tract infections. So you have community acquired pneumonia. Again, the mechanism, the drugs of choice, either amoxicillin with or without clavulanate or doxycycline, if outpatient. If the patient is treated in the hospital, so the choice is mainly co-amoxiclav together with azithromycin or ceftriaxone together with azithromycin. 65 there, if you see, can see there, curve 65 is a scoring system to assess whether a patient needs to be hospitalized for pneumonia or not. So at this point, it's a nice to know thing lah. But when you go into clinicals later, it's a need to know thing. Now it's a nice to know thing. So there are a few things that are considered. Confusion, whether the patient is confused or not, the blood urine nitrogen levels, patient's respiratory rate, the blood pressure, whether it's hypotensive, patient is hypotensive or not, and whether the patient is over the age of 65. So if they score more than 2 in any of these categories, I mean for all the different criteria. So for example, patient is confused, respiratory rate is 35 and patient is hypotensive, that means the patient's CURB 65 score is 3, and that means that the patient needs to be referred to the hospital. Okay, so when you are in a few years time, when you are a junior doctor, for example, after you finish your housemanship, now you are doing your, now you are an MO in a very far away klinik kesihatan in Ulu Tembeling, for example. Okay, or let's say you are in a klinik kesihatan somewhere there lah, in Pahang lah. I'm not quite good with the geography of Pahang. Last I think a month ago or slightly around that time, I had for my first time went to Muazzam. Anybody from Muazzam here? Anyone at all? Anyone from close to Muazzam? Okay. I made the journey from Desaru in Johor, going through Mersing, Kuala Rompin, and then crossing over back to KL via Muazzam, Muazzam Shah. Okay, so let's say you are posted somewhere there in a very far away clinic, and you see a patient. Patient is suspicious of pneumonia. You suspect that this patient has pneumonia, is coughing away like there's no tomorrow. So you assess the patient according to the CURB 65 scoring. So if the patient scores more than 3, definitely you are going to have to make a phone call to the nearest hospital and ask the hospital and tell the MO in charge at the hospital that this patient needs to be admitted. That is the job that you need to do when you are an MO. Okay. So if the patient is penicillin allergic, similar to just now, change to a quinolone. So you consider levofloxacin if the patient is allergic to penicillin. And what about its pharmacokinetics? Anything interesting about the pharmacokinetics of quinolones? Anyone remember?
The grey baby syndrome, is it? Oh, sorry, that's the adverse effects.
Grey baby syndrome. Okay.
Sorry, that was the adverse effects, not the pharmacokinetics.
Well, anything interesting about the pharmacokinetics then? Anyone? Remember, pharmacokinetics is ADME. So it's got something to do with absorption, distribution, metabolism, or excretion. Anything that you need to consider when giving a patient levofloxacin or any kind of quinolone. Okay, patients who are given quinolones.
Doctor, is it?
Yes.
I think was something about like aluminium and magnesium.
Yes,
affecting
exactly.
the absorption.
Yes, exactly. So remember, quinolones, its absorption, there will be interference with its absorption when a patient takes the drug together with aluminium and magnesium antacids, for example. Where do we find all these things? Okay, magnesium in multivitamins, in milk, and even in some types of drugs. They may have magnesium or aluminium content. So if a patient is being prescribed with levofloxacin, and for example, he is also being prescribed with multivitamins, you have to instruct the patient not to take these two drugs together, for example, for a couple of hours. So never take quinolones together with multivitamins, for example, because you might impair the absorption, and once you impair the absorption, you will not get the absorption that you need to exert the actual efficacy that you intend to.
Doctor,
Yeah.
I have a question. In exam setting, for example, during SAQ, if let's say, for example, you're given a case scenario of someone with pneumonia or whatever, so when it comes to the drugs part, will we be given the name of the drug, or do you have to figure out the drug and then give the mechanism of action?
Most of the time, you will be given the name of the drug. Most of the time, okay? Unless it's a very specific case where there will be no other drug that is suitable to treat the patient. Okay?
All right, doctor, thank you.
Okay, but most of the time, because this is pharmacology and not medicine. So medicine in year 5, you will not be given the name of the drug. You will need to figure out yourself what drug to give and what is its mechanism based on the entire scenario of the patient. Okay, but in year 1 and year 2, the focus is more on pharmacology. So most of the time, I would say 90% of the time, you will be given the name of the drug, and from there you just need to figure out the pharmacology. Just excuse me for a minute. Hello? Yeah? Yeah? Oh, saya tak boleh cakap sekarang, saya tengah meeting. Nanti boleh call balik lah kot. Terima kasih ya. Okay. Oh, sorry about that. Okay. Where was I just now? Okay, so for year 1 and year 2, the focus is definitely more on pharmacology, and most of the time, 90% of the time, you will be given the name of the drug, and instead you will need to discuss the pharmacology of it. Describe the mechanism of action, list down the side effects and things like that. Okay. Alright, so that's community-acquired pneumonia. If things get worse from there, patient might have lung abscess or empyema. Okay, and what do we do from there? You will have to adjust the drugs a bit, and see here, you add metronidazole. What did I say just now? If there's an abscess, always give metronidazole, because there is a high probability that there will be anaerobic bacteria in there. Okay, so this is for lung abscess. If the organism is Staph aureus, so patient has a lung abscess, you insert a chest tube and you try to drain the abscess, okay, and you send a sample of the abscess to the lab to determine what is the organism, okay, and it comes back as Staph aureus. So then you know, okay, you can change the antibiotic to cloxacillin or cefazolin. Okay, both are just cloxacillin is both are cell wall synthesis inhibitors. Okay, cefazolin is a fourth generation. Cefazolin is a ceftriaxone. Okay, cephalosporin. Okay. Alright, so that's that lah. Okay. Anybody know what is a rather common side effect of cloxacillin, but rarely mentioned in the textbooks? Anybody have got a cloxacillin injection before? What is a common side effect of cloxacillin injection that is not usually mentioned in the textbooks? Nobody has got an injection of cloxa before. So cloxa, one of the not uncommon complaints of patients when they are administered with cloxa, for example, through an IV line. Okay, you set up an IV line and then you administer cloxa from there. Usually the complaint from the patient would be that the injection site or the site where you insert the granula will be very painful. Okay, so that is just something for you to think about. So something for you to remember. Later on when you are in third year, you see a patient on an IV and you see one of the drugs in the charts, the patient is on cloxacillin. You can ask the patient whether he or she feels a bit painful a lot around the injection site. It's quite common with cloxa, although we don't really know why. Well, it's inflammation, but we don't know why exactly it happens. Okay. What else can happen? Lung infections. If someone has COPD, okay, there may be infective exacerbation of COPD. In COPD, you are having a lot of mucus. Okay, there'll be a lot more probability of the patient getting an infection. Okay, so you can treat that with co-amoxiclav, okay, together with a host of other drugs. So fluoxetine or doxycycline in the outpatient setting, azithromycin, ceftriaxone in the inpatient setting. Okay. Having said that, if a patient of COPD has frequent severe exacerbations of COPD, or if the patient is admitted to the hospital and requires ventilation, requires intubation, then you may suspect Pseudomonas. Okay, so if you suspect Pseudomonas, even before you've exactly identified whether it's Pseudomonas or not, you can always start off with the given regimen. You can give piperacillin and tazobactam together with cefepime, plus minus azithromycin or ceftazidime with azithromycin. Okay, so you give that as empirical after you have taken a sample for identification. Okay, so if you suspect, you give all that. If you have taken a sample and you get the culture and sensitivity report, you treat based on the results of the culture and sensitivity report. But usually Pseudomonas will not have a problem. It will always be susceptible to piperacillin plus tazobactam. Okay, moving on from community-acquired pneumonia, you also have hospital-acquired pneumonia. Okay, and the thing with hospital-acquired pneumonia is that you always have to think about resistance. Whenever you have hospital-acquired pneumonia, always think about resistance and always think about multi-drug resistance, which is more likely if there has been prior antibiotic given within 90 days, or the patient has been hospitalized for a long time in a high-risk ward, or the patient has a history of previous colonization with multi-drug resistant organisms. Okay, so you can see there in the small table there, I've copied from somewhere. You can see the more likely organisms that can be the underlying organism for hospital-acquired pneumonia. Pseudomonas is there, Klebsiella is there, E. coli is there, and also your extended spectrum beta-lactamase producing Enterobacteria. So also likely to cause hospital-acquired pneumonia. Among the gram-positives, you think about strep and you think about staph, which includes your MRSA. So how do you treat? If it's early onset, co-amoxiclav or ceftriaxone. If late onset, you give cefepime or the combination of piperacillin and tazobactam. Alternatively, you can give the penams, imipenem or meropenem, which should be given together with cilastatin. Which brings us to the next question. Anyone would like to volunteer to answer? Question 3.
Maybe just stick with the randomizer.
Okay, fix lah. Nobody wants to.
I can do it, doctor.
Okay, Jana, you want to? Okay, please.
So the question is, what's the purpose of giving imipenem in combination with cilastatin? So usually cilastatin is given in combination with imipenem because imipenem is hydrolyzed by renal dehydropeptidase. So if you don't give it along with cilastatin, it'll be metabolized before it can carry out its function. Cilastatin is an inhibitor of the enzyme that metabolizes imipenem, in short. Yeah.
Okay. Right, that is exactly the answer that we're looking for. Okay, so remember when you give penams, okay, penams must be given together with cilastatin to reduce the metabolism, the renal metabolism and the renal excretion of the drug. So you have a longer duration of action, you have higher efficacy of the drug. Just a simple reason. Okay, so try not to confuse yourself. Not all drugs that are given in combination in terms of antibacterials, not all drugs that are given in combination is because of the prevention of resistance. In this case, it's got nothing to do with resistance. So amoxicillin and clavulanic acid is because of resistance. Sulbactam and ampicillin is given together because of resistance, but not your penams together with cilastatin. It's got nothing to do with resistance. It's just to increase the availability of the drug in the body. Okay, I was trying to finish by 1 o'clock, but it seems that I need to take a few more minutes. So now we are going to talk about the antiviral drugs of interest in the respiratory system. Okay, so you can see a few here already. Okay, you have drugs that act on the neuraminidase, okay, which is essential for viral release from the viral cell. Okay, you have drugs that block uncoating, okay, amantadine, and this used to be used for influenza. In fact, when COVID-19 first came about, we did try this as well, but it didn't work for COVID-19. Okay. And you also have a few other drugs that will act by blockade of nucleic acid synthesis that we are going to discuss later. Having said that, all these drugs you have discussed before, in year 1 in general pharmacology. So read these notes together with your previous notes as well, especially in terms of the details. Okay. So viral pneumonia usually, okay, is caused by these organisms, influenza viruses. Okay. There are instances where viral pneumonia is also caused by herpes simplex or varicella zoster. Okay. There are situations where you have the respiratory syncytial virus, parainfluenza, adenovirus, or measles. Okay. And in Malaysia, for those viruses, the choice of treatment is ribavirin. Okay. And lastly, you have CMV, which can also be treated with your virus, with your ganciclovir. And similar to ganciclovir is for Scarnet, which we are going to discuss in a while. Okay, so influenza can be treated with oseltamivir, which is your neuraminidase inhibitor. Okay, varicella zoster and herpes simplex causing pneumonia can be treated with acyclovir, similar to CMV. And for your other viruses there, you can be treated with ribavirin. These choices of empirical therapy is based on the Malaysian clinical practice guideline. So these are the examples that I am giving you. Okay, this is what happens with oseltamivir. Okay, oseltamivir was also one of the candidate drugs for the treatment of COVID-19 early on, when we first had it. Okay, people were considering using oseltamivir as well. Okay, fortunately also it didn't work. Okay, the live studies has shown that it does not make any difference. If the patient survives, not because of the drug. If a patient dies, also not because of the drug. So it's not effective at all against your SARS-CoV-2. Okay, but this is how it works. So the drug, oseltamivir, inhibits the neuraminidase enzyme, which will in turn prevent the release of new virions, which will prevent the release of the virus and halt the viral replication elsewhere. Okay, so this is what happens with a neuraminidase inhibitor. Okay, next one is ribavirin.
Doctor,
Yeah.
the slide before was about oseltamivir, the mechanism of action.
Yeah.
Okay, doctor, in general pharmacology, the notes we had said that the mechanism of action is like blockade of the viral membrane matrix protein M2, which functions as an ion channel and is required for the fusion of the viral membrane with the cell membrane. So is that considered correct?
Oh, because you learned that with Dr. Jahid, is it?
Yes.
Okay. It's not incorrect lah. It's also correct, but okay. The main mechanism will involve neuraminidase. Okay, the main mechanism will involve neuraminidase. Okay, I would say that the other mechanism that you mentioned just now is also accepted. Okay, so if you answer that in an SAQ setting, yes, we will accept it lah. But the best answer will still be neuraminidase. Okay, is that okay?
All right, doctor, thank you. Thank you, doctor. Thank you.
Yeah. I'm just going to continue here. You can probably hear the azan in the background. I think you can still hear my voice lah. Okay, so the next one is ribavirin. Ribavirin. Anyone would like to try to summarize the mechanism of action of ribavirin into, let's say, 1, 2, 3, 4, 5, 6 into 6 words? Anybody? Ribavirin mechanism of action. Mechanism of action of ribavirin. Summarize into 6 words.
Is a purine analog.
Okay. I don't think you're going to get 6 words. I don't think you're going to get 6 words, Jonathan. Right?
Huh?
Let's just hear it. What's your answer?
It's a purine analog, so it prevents the synthesis of guanosine triphosphate, which in the end prevents DNA synthesis.
Okay, it's correct. It's correct, but it's not 6 words lah. Okay, it's correct, but it's not 6 words. If you want to answer in 6 words, for example, in the SAQ, again, another tip for the SAQ, if we say explain, it's usually 2 marks and above. If we say briefly explain, it's going to be less than 2 marks. So for example, there is a question on mechanism of action of a drug, and the question is briefly explain the mechanism of action of ribavirin. So you can get the full mark, which is 1 mark, just by saying that ribavirin inhibits RNA dependent RNA polymerase. Okay, so that's less than 6 words, isn't it? Okay, so just a tip for you lah. So meaning that if the question is just briefly explain, you can get away with just a short answer. Okay, if the question is explain, then you probably want to go in a little bit more detail, as given by Jonathan just now. So the answer would be a bit longer. Okay, but that's basically the ribavirin. Yes.
Can you repeat the 6th word again?
Inhibition of, that's 2, inhibition of RNA dependent RNA polymerase. Okay, so that can definitely give you 1 mark. If you don't remember anything else, guanosine ke apa benda, purine analog also you don't remember, you can just say inhibition of RNA dependent RNA polymerase. That will give you 1 mark. If it's a briefly explained question, you will definitely get full mark. If it's an explained question, you will not get full marks, but at least you will still pass the question lah. So for out of 2 marks, you will still get 1 mark. Okay, again, just some simple tips for your SAQs. Okay, moving on, and our last question for today. Last question we pick using the random number generator. So who's the lucky last person? It's a boy. Boy pula. It's a guy. Number 21. 21 is Ahmad Al-Mu'min. Are you there?
Yes, Doctor.
Yes. What's your answer?
So mode of the mechanism of action of ganciclovir and foscarnet. Ganciclovir is antiviral, which will inhibit viral DNA polymerase, but it requires activation of triphosphorylation. And for foscarnet, it is also antiviral, inhibit viral DNA polymerase, but it doesn't require activation of phosphorylation.
Okay, very good. That's exactly the answer that I'm looking for. Okay, thank you, Mu'min. Alright, so that's the main difference between your acyclovir, ganciclovir, and foscarnet. Foscarnet is slightly different because it does not require this triphosphorylation process. If you remember your antiviral drugs, most of the drugs will require activation. Most of the drugs will require activation by phosphorylation. So that's the same for acyclovir, ganciclovir, and also for a few other drugs. Even your drugs that are used for treatment of HIV, also they require, most of them will require activation by triphosphorylation. The main difference is foscarnet does not require all that. It can go straight here to the competitive inhibition of viral DNA polymerase. And why is this important? This is important because the mechanism of resistance of viruses to acyclovir, to the acyclovir family, acyclovir, pencyclovir, ganciclovir, the mechanism of resistance usually involves thymidine kinase. The mechanism of resistance here usually involves thymidine kinase. So there are cases where there are reduced numbers of thymidine kinase, or there are mutations of thymidine kinase, or there are even absent thymidine kinase. So if it's not there, the drug will not be able to be activated and it will not work in that particular virus. So that is why foscarnet is important to remember. Foscarnet does not require all that, and it is a viable alternative in cases of resistance. Okay, so acyclovir, the acyclovir family can be used for herpes simplex, varicella zoster. Okay, it's actually quite uncommon to manifest as a respiratory infection. Okay, and also CMV, which is a bit more common to manifest as a respiratory infection. Okay, and similarly, the drug that is the only FDA approved drug for COVID-19. Okay, this is as of now the only FDA approved drug for the treatment of COVID-19. Although having said that, the clinical trials are not very encouraging. Even though it's already approved, still the clinical trials are showing that the effects is, if I can say so-so lah. So not exactly helping, but it's the only FDA approved drug for COVID-19. Okay, and as you can see here in the picture here, okay, it's a bit small, sorry. Okay, but this drug also requires to, you can see here, remdesivir also requires it to be converted into a triphosphate form before it can exert its antiviral action. So remember, most of the drugs that end with vir, also goes to a number of your anti-HIV drugs. They usually require phosphorylation into its triphosphate form. If it's not phosphorylated into its triphosphate form, it will not be able to exert its antiviral effects. Okay, so last part for today is just I'm going to quickly talk about the anti-tuberculosis drugs. Okay, you have gone through the anti-tuberculosis drugs in the PBL. Okay, again, the four main drugs is of course isoniazid, your rifampin, pyrazinamide, and ethambutol. Okay. Of course, you need to remember the mechanism of action. Okay, I know Dr. Kudus or probably Prof. Salas also goes through the list of drugs in their lecture. Just be wary lah. Sebenarnya in the updated research is actually telling us that some of the mechanism of actions is a little bit more confusing, or it's a little bit more complicated. So nevertheless, if you answer according to what you have learned in microbiology pun okay. If you answer according to what you read in the textbooks pun okay. It's not a problem lah. Just that so you know. So remember, isoniazid is inhibition of the microbacterial cell wall via synthesis of mycolic acid. Okay, rifampicin is DNA dependent RNA polymerase. Okay, pyrazinamide requires conversion into is technically a prodrug. Okay, requires conversion into pyrazinoic acid. Okay, but after that, the mechanism is a little bit more controversial. Okay, and ethambutol, you have to mention when you answer the mechanism of action for ethambutol, you have to mention the arabinosyl transferases. If you don't mention the arabinosyl transferases, you won't get full marks. But again, it's just an essential component of the mycobacterial cell wall, the arabinoglycan. Okay, so those are the four main drugs. Streptomycin, not exactly a drug of choice anymore. Okay, but if you answer streptomycin also, it's not a problem. So going back to Jana's question, for example, Jana's question just now kan. So for example, in things like where there may be a number of drugs that can be used to treat one kind of infection. For example, just now if you're talking about community acquired pneumonia, for example, we do not do like you do not need to guess what is the drug that you are supposed to give, because there are a lot of drugs, kan? Okay, but in contrast, if the question is on tuberculosis, for which the treatment of tuberculosis is quite exact, so it always has to revolve around the RIPE, okay, rifampin, isoniazid, pyrazinamide, ethambutol. So in this case, you might not be given the name of the drug. So the question may be this. So the scenario is this patient has tuberculosis, and the last question may be give names of 4 drugs and their mechanisms of action to treat this patient, for example. So that's the situation. If the disease has very definitive drugs for which to choose from, for example, tuberculosis, definitely being treated with RIPE, then you definitely need to remember exactly what the drugs are lah. In contrast to, for example, what I said just now, community acquired pneumonia, where the drugs can change according to situation, so we don't usually simply ask you to give the name of the drug. Okay. Okay, so remember the mechanism of action, and also don't forget to remember the toxicities as well. Okay, there are a few things that are favored by lecturers to ask in questions. For example, rifampin causes your body fluids to turn orange. Okay, I think did you learn about tuberculosis drugs in year 1 ke tak? General pharmacology. Did you learn about it or not? I forgot already. Yes or no?
No, I don't think so.
No,
I think Dr. Jahid changed it last year. So, but before that, it was in the syllabus in general pharmacology as well. But at least in this block, you've already learned it twice lah, in the PBL, and also mentioning it again here. But you can see here in the last column there, the toxicities. So there are a few peculiar toxicities that we like to ask about. But as a matter of fact, the most important toxicity for these 4 drugs, all 4 drugs, is actually the hepatotoxic effects. So if you don't remember anything about the toxicity of anti-tuberculosis drugs, please try to remember that most of the drugs, in fact all of them, even though here in rifampin here it does not say hepatotoxicity kan, tapi sebenarnya each of them, all 4 of them, okay, is hepatotoxic. So if you cannot remember anything, please remember that treatment with tuberculosis, there is always a risk of hepatotoxicity. Okay, so how are you going to monitor the patient who is being treated with anti-tuberculosis drugs? What blood investigations are you going to use to monitor their response?
Response to what again?
What blood investigations are you going to monitor to monitor, to gauge their risk of hepatotoxicity? What blood investigations are you going to do?
The liver enzymes thing.
Yes,
Test.
the liver function test. Okay, so remember, if you have a patient on on anti-tuberculosis multi-drug therapy, always monitor their liver enzyme levels. So you do a liver function test, you monitor their liver enzyme levels. If they are raised, then it raises the question whether there is damage to the liver or not. Okay? All right, any questions? I think that's all for today. The previous slides are all on, actually on, also on tuberculosis. You can see some other drugs that we can use for tuberculosis as well. Okay, any questions? There are no questions now. You can always contact me later if you have any questions. Okay, good luck for your next block. Okay, I think Dr. Sarah has mentioned to you about what's going to happen later on. So from now on, the mid-course examinations will be going on online, but the end-of-course examinations will be postponed, and there will be some changes to the academic calendar as well. Okay, all right, if there's nothing else, thank you very much. And
After the attendance.
yeah, of course you can do that now. Okay, thank you very much, and see you after the CMCO.
Thank you,
Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.